Hello, how are you? We are with Dr. Professor Holger Thiele. He's from Leipzig, Germany, and he's going to tell about what happened in the last Congress in Argentina of the Argentine Society of Cardiology. How are you, Professor? It's an honor to have you here.
Yeah, I'm doing fine. It's a pleasure for me to be here, to be invited to your Congress. It's a huge honor for me to be here.
First time here in Argentina?
Yes, it's the first time for me to be in Argentina.
Okay. So the first question it appears in my mind when I'm with you. It's to talk about cardiogenic shock. Ischemic cardiogenic shock, and you are the most important interventional cardiologist that develop all the background where we stand today when we have a patient in our cath lab. How do you begin this history of doing this step by step to these patients?
Good point. So I can tell you. So when I was a young interventional cardiologist, my former boss, so I had a patient in pre-shock, but he had elevated lactate, but he had normal blood pressure. And I have done a PCI in the night, and my former boss blamed me in the morning. Why haven't you put in an intra-aortic balloon pump in this patient? I said, so patient had normal blood pressure, and despite having some lactate, but there's no evidence that this patient really needed an intra-aortic balloon pump. No, the guidelines say it's class 1, that you have to put in an intra-aortic balloon pump. And then I said, okay, looked up all the evidence behind it, and I said, this is something which needs to be done in a randomized trial. This is what I have done. So this was the motivation to be blamed in the morning that I haven't put in an intra-aortic balloon pump. I said, this is something we have to prove. And that's the reason why we have done the randomized IRPP Shock 2 trial, which now is more than 12 years ago. But this was the first milestone to do this, because I said, I want to prove that the intra-aortic balloon pump is working. So, but this is exactly what I wanted to do.
Okay, thank you. And nice story. And what do you think when we saw the guidelines and we read routine use? We must not use in routine use. Is there a place where we must use it or never?
I know that this is an emotional discussion often, because often in some regions of the world, the intra-aortic balloon pump is the only device which is available. And I understand that you want to put in something because you know that otherwise 50% of the patients die. That's the reason why we want to do everything what we have in available in our cath lab. To be honest, after having done the trial and after having done all the sub-analyses, this is also important. I don't see any subgroup who really have a benefit from intra-aortic balloon pump. And that's the reason why, at least in my institution, and also the same is true in Germany, because many centers have participated in our trial. They don't use the intra-aortic balloon pump anymore.
Okay. And what do you think when they say, okay, there's a subgroup of patients, not in shock, but to make the perfusion better, when they say the coronary flow, and maybe, what do you think?
We have randomized trials for this question, very old randomized trials, but there are also meta-analysis on this, which did not show a mortality benefit, which even did not show any benefit regarding reperfusion. So TMI flow or maybe ST segment resolution. There's no evidence that the intra-aortic balloon pump, despite its possible beneficial effects on increasing the diastolic blood pressure, there's no evidence that it really can improve perfusion. That's the reason why I would not use it in this setting. I know that still some people say, okay, SCAI shock class B, this may be an indication, but this has never been proven in a randomized trial. So maybe this is the motivation for some people saying, okay, I want to do a randomized trial in shock, SCAI stage shock B. do a randomized trial. Then we will know it. Yeah? But for heart failure-related cardiogenic shock, we have now the ARCH-SHOCK-2 trial, which has been done in mostly SKY shock C, but also B. Those were patients in pre-shock and in classical cardiogenic, most of the patients. And the trial was stopped. This was heart failure-related cardiogenic shock, stopped early because of futility, which tells you it does not work.
Okay, thank you. And okay, the next step was the ECMO. And you go over there, you have a slide that you said that your fellows made it. It's wonderful when you knock the door. And you also appears the ECMO trial, and what happened?
So this was also the motivation. So I saw that after our IBP Shock 2 trial has been finished and the guidelines have been changed, we had a explosion in the use of ECMO in Germany and also in other countries. This is what I've seen, at least in France, everywhere, because nobody was believing in the angiotic balloon pump anymore. So then they were looking for, we need a stronger device. And that's the reason why we had an explosion. 100 times explosion in the use of VA ECMO in Germany. That's the reason why I said, okay, we have to do a randomized trial on this. This is what we have done. But the trial, once again, turned out to be negative. There's a lot of discussion on this, maybe some crossovers. The high rate of resuscitated patients may have played a role. Honestly, I do not understand why the trial has been negative, because I have been a believer and I'm still a believer in VA ECMO, but for selected patients. This is what we have shown, that for routine use in cardiogenic shock, it's not working.
Okay. And the last, the Impella trial. That incredibly, it was the danger shock really positive. We never expected that.
Yeah, I know also from the group, from the danger group, that they were also, after having seen the results of our trial, they were saying probably our trial will also not be positive. In the end, it turned out to be positive, which is nice. So we have now a positive randomized trial in cardiogenic shock that a mechanical circulatory support device is able to reduce the mortality. But there's still questions regarding the trial. I've shown this during my presentation, during the meeting. So the increase in mortality over time, this is something from 30 days to 6 months. This is something I do not understand, because this is higher than in any other previously randomized trial. Then there's also some issue regarding the fragility index, because only 2 more patients in each group dying or not dying would have made the trial negative. And then the other thing is, currently it's only a very highly selected group. It's only STEMI without risk of hypoxic brain injury. That's the reason why I personally believe, and also the danger shock steering committee, they believe we need another trial. This is what we are currently preparing. We currently prepare the so-called double shock trial, which is randomizing patients to Impella or maybe any other microaxial flow pump versus control. And once again, so it's a 2x2 factorial design. We also randomize to Swan-Ganz catheter versus no Swan-Ganz catheter, because everybody, particularly in the United States, believes the Swan-Ganz catheter is able to reduce the mortality. I'm not 100% sure, and this is what we want to show. So if it is possible or able to reduce mortality, this is something we have to use in every patient. But currently, at least in Europe and also in Germany, we are only using it in selected patients currently, and not routinely.
Okay. And another question from that trial, I read a sub-study that was against the evidence until now that says that culprit only is better than multiple vessel revascularization. Sorry. That the evidence said that culprit only shock, cardiogenic shock, your information also said that it's better than culprit only, but this danger shock go against that also. A sub-study said something different. What happened there?
So, first of all, we have a randomized trial in more than 700 patients showing that culprit lesion only with allowance of stage revascularization is reducing mortality with a number needed to treat of 12 versus immediate multivessel PCI. So we have a randomized trial. In danger shock, this is a sub-analysis, a non-predefined sub-analysis with a lot of bias. And some people say it's because of the impeller. No, this is not because of the impeller, because 50% of the patients having got only curpid lesion versus immediate multivessel PCI had impeller or not. So this is not the effect of the impeller. This is it's a registry. So, and based on registry data, we do not make any decisions. This is what, if you ask me, this is what if you want to balance these results, this doesn't tell you anything. What tells me something? It tells me that we do not follow the guidelines. This is something which is a little bit disturbing. So the danger shock trial was a trial which was lasting more than 10 years for patient inclusion, which I understand that initially, because the guidelines said it's a 2A recommendation to perform immediate multivessel PCI in all these patients with a level of evidence C. But after our trial came out and the guidelines have been changed, the percentage of patients undergoing immediate multivessel PCI in danger shock remains the same, which honestly, so we have guideline recommendation. It's a class 3 recommendation to not do it in the American guidelines as well as in the European guidelines, but the people do not follow the guidelines. This is something what we have what we can learn from this analysis. And this is a little bit something I do not understand it. We know that it's increasing mortality, but we still do it.
It's very interesting. Very interesting. And last question. What do you think about a lot of mortality in cardiogenic shock, 50%? Is there a place to, I don't know, inflammation, anti-inflammation drugs, somewhere over there that we are not seeing?
I think we are already seeing it. So we are putting more attention to the problem of inflammation. So this excessive inflammation, what we see in cardiogenic shock, we know that if interleukin-6 goes up, if C-reactive protein goes up, this is an indicator of very high mortality. Currently, we have no tools on changing or modification of this inflammatory response. This is probably something what we have to do. But once again, I don't think that it should be done routinely. Probably we will have to measure something. We have to measure like interleukin-6. There are also some other markers like circulating DPP3. And there is currently a specific drug which is able to address the significant increase of DPP3. We have to wait for this. Currently, there is a phase 2 trial for this specific drug for DPP3. Which is currently just in the beginning phase, but we need these randomized data. But still, the question is which patients should be included there. Probably it's not a routine for every patient. This is probably very important.
Okay. Thank you really very much for this conversation, and I learned a lot. I hope the ones over there are going to learn as I did. Thank you very much.
Thank you very much once again also for the invitation here to Buenos Aires.